morning. I'm Dr. Kim Allen Williams, and welcome to our University of Louisville Medical Grand Rounds. I'm the chair of medicine, and it's my distinct pleasure this morning to introduce our introducer. Our speaker will be Dr. Rohit Kumar, who is assistant professor of medicine in the oncology division and Brown Cancer Center here at University of Louisville, speaking about renal cancer. But the real introduction will come from our own Dr. Elizabeth Riley. She is our professor of medicine and deputy director of the health affairs at UofL Health and Brown Cancer Center. She's our section chief for medical oncology and benign hematology and the director of the breast cancer multidisciplinary clinic. Dr. Riley, take it away.
Thanks, Dr. Williams. So it's also my pleasure to introduce Dr. Kumar, who, when I was thinking about what I was going to say a rising star, but he's risen so far, already. I don't know, how we can still say that, but he's a homegrown success story. He did his fellowship here at the University of Louisville after doing residency in internal medicine at John H. Stroger Hospital in Chicago. And one thing I learned in reviewing his CV that he did a hospice and palliative fellowship at the University of Arkansas, which Rohit, I didn't know that at all, which makes sense to me, understanding what a great bedside clinical care physician you are. I really appreciate your good care of patients. But he is a rising star. He's both productive clinically, but academically is one of the leaders in our novel early phase program focusing on GU malignancy, but also has some really interesting tumor agnostic studies. So we could not learn about renal cell cancer from anyone more qualified than Dr. Kumar. So I appreciate him giving this talk today, and I know everyone's going to enjoy it.
Thank you, Dr. Riley. And thank you, Dr. Williams, for the invite to talk here today. I'm going to get started. I'll be talking about the current treatment options for renal cell cancer, which since I've been in training, that's just, not too long ago, and just for last 4 or 5 years has significantly changed from compared to a few years ago when we had, very few options. And honestly, those options were very, very toxic. So most of our patients were not even a candidate for those options. So I'll move along. So these are my disclosures. I'm the institutional PI for a clinical trial from Merck, Eli Lilly, and Arcus Bioscience. The learning objective for the talk today is we'll talk briefly about the epidemiology of renal cell cancer, and then spend most of our time talking about the current treatment options. And since we have so many options, how do we as an oncologist, personalize treatment for our patient in clinic? And then briefly about what's in the pipeline for renal cell and where the field is heading as a whole. So I'll start with a clinical case. This is a 65-year-old male who is diagnosed with a de novo metastatic clear cell renal cancer with mets to lungs, bone, and retroperitoneum. So stage 4 from the get-go. No significant past medical history. KPS, which is a scale of performance status, is very good for this patient, 90%. And then neutrophils, calcium above upper limit of normal hemoglobin, and platelets. So my first question is, what's the frontline option? What are the options for these patients, which obviously I'll discuss as we go along this talk. But the second question I want the audience to, if someone can comment in the chat box or just think about it, what does maybe non-oncology field, what is the impression, what is the survival as of now for a stage 4 renal cell cancer patient? I know we cannot do polling, but maybe, as a group, maybe have a number in mind, and I'm hoping to pleasantly surprise you at the end. So moving on to some epidemiology, renal cell cancer is not one of the common cancer. If you see in male population, is about 6th, comprising about 5%, and in females about 9. So in total, there's about 80,000 cases annually. Unfortunately, American Cancer Society combines kidney and renal pelvis cancer together when they give us the incidence. But kidney cancer and renal pelvic cancer is completely different entity. But the numbers are combined. Median age for kidney cancer is about 64 years, with males twice as likely developing the cancer as females. Asian Americans had the lowest incidence, and Fortunately for renal cancer, there is no racial disparity in survival or incidence. And I think that this also goes along the fact that there is unfortunately no screening for renal cell cancer. And we know a lot of those cancer which has kind of a racial disparity, access to healthcare is an important factor. Since we don't have any screening for renal cell cancer, most of the time it's an incidental finding. Survival outcomes, fortunately, are similar across all racial groups. So as I said, the annual incidence for renal cell cancer and pelvic tumors combined is about 80,000, and which with mortality per year about 15,000 of these patients die of kidney cancer every year. Looking at stages diagnosis, fortunately, although there is no screening for kidney cancer, as you can see, the red bar, most of the cancer, renal cancer, is diagnosed in localized state. And about 15% in regional when the cancer from kidney goes to surrounding lymph nodes, and only about 15% of kidney cancer is diagnosed in metastatic stage 4 setting. So the good thing about this is localized and regional surgery up front is still curative. So majority of the patients are able to go have the curative option, which is usually surgery plus minus some adjuvant therapy. And again, as you see across African American and white population, the incidence stays almost the same in different stages. Now, talking about some risk factors, smoking is one of the risk factors for RCC. Even to start with all the risks, I would say the biological reason for most of these risk factors, like why does this risk factor predispose patients to renal cell, is not fully understood. But smoking, we know, is a carcinogen, induces a lot of mutation. So the relative risk for current smokers is about 1.3. For past smokers, it does go down, but the risk never goes down to general population. Hypertension is one of the risk factors and actually has been reported about 67% increased risk of RCC in patients with hypertension. Again, the biological reason for this still remains largely unknown. Interesting fact about obesity, if the high BMI is actually associated with increased incidence of RCC, but patients who do have RCC and have high BMI tend to have like a more indolent RCC. So yes, incidence increases, but the disease for, again, reason unknown, does follow kind of an indolent clinical course. Acquired cystic disease or chronic kidney disease, especially in patients with dialysis, significantly increases, about 30-fold increase in risk of RCC. And then obviously genetics plays a major role. We know there's a lot of syndromes where, this is a familiar disorder. More commonly about this VHL genes, which is associated with other cancer as well. So germline VHL is associated with clear cell. MET germline mutation is actually associated with a variant histology called papillary RCCs. And then, there's other mutations like succinate dehydrogenase, which is also associated with GIST tumors. Paragangliomas is also one of the mutations which can predispose to RCCs, and the tubular sclerosis. These are some mutations where you can have, kind of a genetic syndrome, and RCC is part of it. Chronic and frequent use of analgesics, aspirin and NSAIDs, is also increases risk of RCC. The data is a little bit confounding. It's not known that if it's directly related, or is this chronic analgesic use, does it lead to CKD, which is a known risk for RCC. So there is some confounding, but there are some studies which they try to kind of adjust for those confounding factors and still found a relative risk of 1.5. Occupational exposure to heavy metal like cadmium and petroleum products increases risk about, relative risk is about 1.4. And most interesting on these is actually hepatitis C has been also associated with RCC. Historically, we relate HCC to hepatitis C to HCC, but there is decent data which shows that Hep C actually increases the risk of RCC, and most likely because of the viral The virus itself causes a lot of immune modulation, activation of immune system, causing chronic inflammation, and immunosuppression probably is related reason for predisposing to RCC as well. The data honestly is from, I know the hepatitis C treatment has significantly improved lately. The data is pre that treatment era. So impact of this effective treatment on RCC, is something it is just not, data is not available, but would be interesting to see if the RCC, the incidence has decreased in patients with HCC who are on effective treatment. Moving on to RCC subtypes, there are different type of, when we call renal cancer cells, it's not just one cancer, there are different types. And most of these subtypes are divided based on the origin of the cells, the growth pattern, the morphology. So the most common type of renal cancer is on the left top, which is the clear cell. Basically, these, as you can see, these cytoplasm are very rich in lipids. So you can see that clear cell appearance. And that's how it gets its name, clear cell RCC. It comprises almost 80% of our RCCs, and the next two common subtypes are papillary, which it gets its name from spindle-like growth patterns. They're type 1 and type 2s, which makes about like 10 to 15% of all RCCs. And the chromophobe is about 5%, and collecting deck medullary are other rare type of RCCs. Lately, there has been a trend to further classify RCC based on mutations. So if RCC like associated with ALK rearrangement, RCC associated with RCC associated with fumarate dehydrogenase mutation. So basically defining them from the mutations, underlying mutations. Majority of the talk we'll have today will be for clear cell because that's the most common and most of the data is from clear cell. And I have few slides at the end about non-clear cell as well. Very quickly about staging, because this will kind of guide a little bit how we do the treatment. So stages, stage 1 to 3 is a localized or local regional disease. Stage 1 and 2 is localized, just contained within kidneys. And stage 3, they spread to lymph node or renal vein invasion. Stage 4 is when surrounding structures like adrenal is involved, or there's distant metastases or non-renal lymph nodes. Stage 1 to 3 is considered most of the time resectable and curative with surgery. Before I talk about the systemic therapy option, as I alluded before, before this targeted therapy and immunotherapy was available, there was very few therapies available for RCC. And multiple times we have tried cytotoxic chemotherapy, but it showed no benefit in patients with kidney cancer. So the slide I have up here is showing some of the pathogenic pathways in kidney cancer, which leads to angiogenesis and cell proliferation. And some of these targets are the targets for current medication, and some of them are actually part of active research. So I would focus on just the right side of the slide because that's the main pathway. The PK, the receptor tyrosine kinase pathway activation in kidney cancer cells leads to downstream activation of PIK3 kinase, AKT, and mTOR pathway. All of these targets, either are FDA-approved drugs or part of active research. The other important pathway is actually VHL mutation. It can be germline or sporadic, which leads to overactivation of hypoxia-induced factor, and which is a major driving force for renal cell cancer. And fortunately, the drugs are in development for hypoxia-induced factor. In combination, all this activation of this pathway ultimately leads to angiogenesis and cell proliferation and invasion and ultimately metastasis. So this is one of the major pathways for RCC. On the left, this is more kind of basic science research, but I know everyone has heard about TP53 mutation, which is a gatekeeper gene responsible for a lot of cancers. For some reason, TP53 mutation is not very commonly found in RCC. Although the mutation is not found, the renal cancer cells actively kind of using autolysosome metabolizers degrades the P53 gene, although mutation is T53 is rarely found. Again, this is a part active research. No clinical blocker for these pathways are available yet. And again, this is just circling the stuff which is already approved. So we are blocking tyrosine kinase inhibitors, which I'll go in detail. And then we also have hypoxia-induced factor inhibitor. Okay, I'm really hoping my boss, Dr. Chesney, is not here because he will kill me for trying to explain immunotherapy in one slide. But I just have to give you an overview because this will be a major discussion for treatment options. So, this just one slide, but doesn't necessarily mean this all stuff is happening in one location. A lot of this stuff happens in tumor microenvironment. A lot of stuff actually happens in lymph node, in the periphery as well. So basically, we all know whenever this is true for cancer or any antigen presentation that the tumor cells or the APC cells actually present the antigen to T cells on MHC, which is recognized by T cell receptors, which is the main path. And then there's post-stimulatory pathway with CD28 and B7. So most of the time, T cell is activated with antigens, but when the cancer is presenting the antigen, it also has other pathways to, even after activation of these receptors, to silence the T cell, which is our main immune cells. So those pathways mostly is PD-L1, PD pathway, which once activated, lessens the T cell activation. And the other commonly, targeted receptor is actually CTLA4. So obviously, once we figure out these pathways, drugs were developed to kind of block this pathway, which the tumors are using to silence the immune system. But again, this is not a, it's a very oversimplified slide, and honestly, it doesn't do justice to field of immunotherapy. So these will be two kind of main classes of medication. We'll be talking through some combination of these medication throughout this talk in managing kidney cancer. So let's start with some local and regional disease, which is mostly stage 1 to stage 3, and some of stage 4 is also resectable. So surgery is curative for majority of localized and select oligometastatic disease. The definition of oligometastatic disease, like number of metastatic disease you will call as oligo, is very fluid and not well defined. If you look at the 5-year survival rate for localized, which is mostly your stage 1 and stage 2s, just surgery by itself has cure rate of upwards 93%. So survival is actually 93%. With regional disease, where the cancer is slowly trying to, spread, which is to your lymph node, renal vein, the 5-year survival rate goes to 72%. So most of the time, surgery is curative for localized disease, but there, in that umbrella of local regional disease, there is a intermediate high risk patients, which usually in our field is defined by at least 20% disease recurrence rate in 5 years. And those are the patients we feel like even after surgery, we can intervene with some systemic therapy to further improve the outcome. And I'll show you data for that. But surgery remains the mainstay for localized therapy. I'm showing a graph here, which is almost 15 years old, which kind of, this is where the data for doing surgery for oligometastatic disease came out, which shows even if you have oligometastatic disease and it can be resected, getting a complete resection increases significantly your cancer-specific survival, which is 4.8 years versus 1.3 years, and also increases your overall survival. This data is pre-TKI and immunotherapy. So relevance of doing, doing surgery on oligometastatic disease in a modern era of treatment is not known, but this is still part of NCCN guidelines. Even if a stage 4 disease is resectable, to strongly consider it. So I just mentioned that, there, even in localized renal cell, there is a small proportion of patients who do have high risk of recurrence. So how do we know who are these patients? Who do we offer additional therapy after surgery? So luckily, there's a lot of risk calculators. The one I use is developed by Fox Chase Cancer Institute. It's called Assure RCC risk calculator. But there's UCLA calculator, there's Mayo. So all of them are really good. I just personally prefer this one. And on the slide, I have all the variables. You kind of, it's an online, you can go to this link put in all the variables for your patient, the age, the size, what type of histology, what was the hormone grade, was there necrosis, was the lymph node involved, and other pathological findings. This is after surgery, so you need surgery to get all this information to plug into this calculator and figure out what's the risk for your recurrence. General consensus is at least if you have 30%, it's a strong reason, which is a high risk of recurrence to consider adjuvant therapy. But between 20 to 30% recurrence rate, which is intermediate grade, is a discussion in clinic we have with patient, more kind of individualized. But about 30%, everyone agrees that patient needs something extra besides just surgery. So what options do we have after surgery? This just recently came out in not too long ago in 2021, Keynote 564, which actually looked into giving Keytruda, which is an immunotherapy, within 12 weeks of surgery. Surgery can be just localized, like nephrectomy for kidney cancer, or they also allowed resection of metastatic disease within a year of diagnosis. So if you had resection, they complete resection of the primary and the metastatic side, they randomized to 1 year of Keytruda versus placebo. Primary endpoint was disease-free survival, secondary was overall survival and safety. So this is the risk category they used to enroll a patient. They didn't want to enroll low-risk patient. As I said before, those are mostly cured by surgery itself. So I use Fox Chase, but this trial actually used the UCLA risk groups, and they use at least intermediate and high risk, which you can see the pathological finding. If you are stage 2, you have to have very high grade disease, sarcoidoid feature, which is a high risk pathological features, or stage 3, or involvement of surrounding structure with lymph nodes, or had already stage 4 disease but was resected. And if you look at the left, as I was mentioning, at least 20% and above recurrence rate is where you actually think about giving adjuvant therapy. So as you can see in the lowest risk group population of this study, there was a 20% risk of recurrence, which goes up to almost 80% of recurrence within 3 years if patient has metastatic site. So these are some high risk patient of recurrence, even though after surgery. So this was the primary endpoint. The study did meet its primary endpoint. 24-month disease-free survival rate was 77% compared to 68%, with hazard ratio of 0.68. Median has not yet reached. They recently published a 30-month follow-up data, but median is still not reached. If you look at the subgroup analysis, almost all the risk groups, all the stages, and especially the stage 4 oligometastatic disease resected derived benefit. Actually, for the M1 disease, which is a resected stage 4 disease, the hazard ratio was 0.28. So significant benefit across all subgroups. Some of them do cross 1, but these are subgroup analysis, and the study was not statistically powered to have, to detect difference in each of these subgroups. As we speak, as of now, the overall survival, which is obviously gold standard for any cancer treatment, is not mature. They did have an interim analysis with some pre-specified benchmarks. The study did not meet the interim benchmarks. So overall survival of giving Keytruda in adjuvant setting, even for these high-risk patients, is debatable, but disease-free survival is established. Because we use the same drug in stage 4 also, the timing may matter. So we know it's a disease-free survival for sure. Whether it will, in final analysis, it will pan out to an overall survival benefit or not, it's yet to be known. So the next question, obviously, there is side effects. The side effects do justify the benefit. In my opinion, they do. In the last row, you will see treatment-related side effects. Overall, all side effects was about 80%, and people about 50%, even in placebo arm, had side effects. But what we focus mostly is on grade 3 and grade 5, which are significant grade side effects, which was about 20%, which with our experience with this Keytruda with other cancer is what we see in other cancer as well. So which I do feel that 20% side effects is worth the benefit of disease-free survival. And honestly, and more we are giving this immunotherapy to patients with different type of cancer, more we are getting comfortable managing the side effects as well. There will be few patients who are not eligible for immunotherapy for various reasons, their autoimmune disorder or some other reason. So obviously the other question is there any other option besides immunotherapy for these patients? There is an FDA approved drug called sunitinib, which is a TKI, a tyrosine kinase inhibitor, which I'm on the right, I'm showing a meta-analysis, which besides sunitinib, they have done study on multiple other TKI, and none of them has shown any benefit, disease-free or survival benefit. For some reason, the S-track study, which had sunitinib, did show some disease-free survival at the bottom here, but no overall survival. So that led to FDA approving the sunitinib for adjuvant study. But even before Keytruda came out, we were rarely using sunitinib just because the meta-analysis didn't show any benefit, and overall survival benefit was not there. So as of now in our practice, if we do give something adjuvantly, is Keytruda. Otherwise, a patient goes on active surveillance. Now moving on to metastatic disease, where we have made most of the improvement. Most of the slides I will show you is related to clear cell, which is the most common, but I will at the end show you some non-clear data as well. I will go through most of this slide quickly because there's a lot of trial data, but I do have summary slides at the end, and we will spend some time on those slides. So when we talk about systemic therapy options, what are we talking about? Is it chemotherapy? No. Chemotherapy has never shown any benefit in kidney cancer. When we talk about systemic therapy, we're talking about some combination of immunotherapy, either a doublet immunotherapy or doing some immunotherapy plus tyrosine kinase inhibitor combination, or patients who are not eligible for immunotherapy, their data to support tyrosine kinase by itself. Before moving to discussing the trials for these systemic therapy option, I do want to present this slide because this plays an important role in what treatment we offer patients, what prognosis those patients have, which is the IMDC risk stratification. So this is an old risk stratification, but we still widely use it in practice and in clinical trials. We use a lot of clinical information like performance status, time from diagnosis to need for systemic therapy, and then hemoglobin, neutrophils, platelets, and calcium levels. We use these factors to risk stratify a patient into favorable, intermediate, or poor risk. And again, the data for risk stratification comes way before TKI and immunotherapy. And so there's a lot of debate if this still holds true in modern era, and they are trying to improve. I'll show you some trials later on the risk stratification, but as of now, we do use it in our practice and trial. So if you risk stratify based on these risk factors, you will see the graph separates beautifully. The overall survival for the poor risk is significantly low compared to the intermediate and the favorable risk. And I'll show you this trend as we move along the slides. We know it's not just gives us a prognostic information, it also tends to predict these patients, how will they respond to TKI versus immunotherapy. So for instance, favorable risk patients have little to no benefit. Let me say the majority of favorable risk patients have little to no benefit from immunotherapy. They respond more to VEGF, like a tyrosine kinase inhibitor. And as you move along the intermediate and poor risk category, those are the patients you will see response to immunotherapy. So this is an important piece of information we discuss with our patient when we are offering them treatment. So moving along with the trial, as I said, we do give one of the most common combination we give is combination of two immunotherapies, nivolumab and ipilimumab. So this was the Checkmate 214 trial, which led to the approval of the combination. These were treatment naive clear cell patients with good performance status and measurable disease. And the trial stratified them on based of their IMDC risk stratification. So they randomized to arm A, which was Nivo, 3 milligram per kilo plus IPI 1 mg per kilo for every 3 weeks for 4 doses. And if you don't progress, then you go on to just single agent nivolumab maintenance. This was compared to then standard of care, sunitinib, which is a tyrosine kinase inhibitor. And the treatment was continued until progression or unacceptable toxicity. The primary endpoint was overall survival, progression-free survival, and overall survival in intermediate and poor risk, but secondary outcome, they did look at all risk groups. So looking at all risk groups combined, which are intention to treat population, this is a almost 5-year updated data, which overall you see a 55 months for a stage 4 cancer patient, compared to 38 months with TKI alone. Which did meet statistical significance. P was less than 0.001. But if you look at the progression-free survival, they're very similar, and it did not reach statistical significance for overall population. But I want to show you next is subgroup of these patients. So as I told you before, intermediate and poor risk are patients where we expect them to respond more to immunotherapy. Since the experimental arm had only immunotherapy, that's why I feel like the overall population didn't mean the progression-free survival. But if you look at the subgroup of only intermediate and poor, both overall, both overall and progression-free survival was significantly different than TKI alone. Now, looking at the favorable risk, the curves almost overlap for overall survival. And actually on the right, there's a very interesting thing which happened here. The control arm did much better than the experimental arm in favorable group. And again, that goes along with saying that favorable risks tend to be more VEGF driven. So blocking VEGF with tyrosine kinase inhibitors had better outcomes in favorable. So when the approval came out, the approval for the ipi-nivo combination is actually only for intermediate and poor because of this data that showed that ipi-nivo actually is worse than TKI alone or TKI combination. Now we are looking at the table with objective response rate. So if you look at the overall population, combination of ipi-nivo had about 40%. Again, which was mostly driven by the intermediate and poor risk group, and the favorable, and again, because we don't expect a lot of response with immunotherapy, was about 30%. And then it goes into detail about how many complete responses we see, which is about 11% compared to only 3% in TKI alone. Now moving to the other combination, which is a tyrosine kinase inhibitor plus immunotherapy option. Again, eligibility criteria are very similar to our previous study: stage 4, clear cell, untreated, measurable disease. They were randomized to experimental arm, which was Keytruda with immunotherapy plus axitinib, compared it to sunitinib, the standard of care. Primary endpoint was overall survival and progression-free survival. Looking at overall survival in intention to treat population, you will see here, hazard ratio, there's about 27% reduction for overall survival in patients who got combination TKI and immunotherapy compared to TKI alone. Moving along to progression-free survival, again, the benefit was there in the experimental arm of pembro and axitinib, hazard ratio of 0.68. Now, looking at response rate, as you may recall, immunotherapy combination had about 40% response rate. TKI and immunotherapy combination tends to have much more response rate, about 60% compared to 40% with immunotherapy alone. And there were decent amount of complete responses, about 10% with the combo. Here I'm showing just the subgroup analysis. Again, you will see the same trend as we saw in immunotherapy combination, that favorable risk group doesn't derive much benefit from adding immunotherapy to TKI. But when you look at the intermediate poor, these are the cancers which are more immunogenic and response to immunotherapy better. Combination did not, in my opinion, did not significantly increase the side effect compared to just doing TKI. So if you look at the grade 3, grade 5 side effects, the combo arm had about 67% side effect compared to just doing TKI, which was only was 63. So not a big difference, which tells us that most of the side effects actually comes from TKI. Combining Pembro didn't add much side effect, but definitely has significant benefit. Again, these are very similar trials, so I'm going to quickly go through this. This is Checkmate 9ER, which led to combination of cabozantinib, another TKI, and Nivo. And again, they also compared it to sunitinib. Very similar design, very similar outcome. Hazard ratio, again, 0.7 for overall survival, and hazard ratio about 0.56 for progression-free survival for this combo as well. Objective response rate, very similar to other TKI and IO therapy, about 60%. And again, we are seeing about 10% complete responses in TKI and IO therapy. Again, side effect profile, very similar. Adding nivolumab to TKI didn't significantly increase the side effect profile. And this is one of the last study which led to approval of lenvatinib, another TKI, and Keytruda, very similar design, except they had a third arm which had Lenvima and everolimus, which is mTOR inhibitor, which has fallen out of favor. When they presented the data, they only focus on the TKI and immunotherapy arm, which again follows the trend of other TKI and immunotherapy, progression-free survival benefit with hazard ratio of 0.47, overall survival benefit with hazard ratio of 0.78. Again, objective response is also similar, about 70%. Honestly, numerically is much higher than any other TKI and IO combination. Here it shows 71%, and even complete response is slightly higher than other TKI and IO. But we like to avoid, cross-trial comparison. But if you look at the numerical numbers, the response rate was higher for Lenvima and Keytruda. So this just summarize this in all this trial we just discussed. So these are all the trials, 4 trials I just showed you data on. If you look at the baseline characteristics, what was the percentages of different risk categories? What was the percentage of sarcoptoid features, which is a high-risk pathology? How many patients had recurrent disease? How many had liver disease? So across all the trials, very similar baseline characteristics. Moving on to efficacy, you will see the most follow-up data we have is for the ipi-nivo combo arm. So you will see that overall survival for stage 4 patients now is reaching close to 5 years. And it's showing less on the other trials, but this is just because of shorter follow-up. I think when they have longer follow-up with the TKI and immunotherapy arm, it will get very close or even better for these studies as well. Objective response rate is across the board higher, much higher for TKI and immunotherapy compared to immunotherapy, which is just 40%, and 60 to 70% for TKI and immunotherapy. So if you're looking for a response, patient is very symptomatic, TKI and immunotherapy is something we offer to our patients. Going on to safety, in my opinion, and the data suppose that immunotherapy combination is usually well tolerated. There were less grade 3 side effects compared to any of the TKI and IO combination, and less discontinuation as well. So if I have a patient who have concern about performance status, tolerability, I do tend to favor ipi-nivo unless if they are favorable risk and they're not eligible for it. But TK and IO, although has good response rate, does come at cost of more side effects. So we have to very carefully select these patients in our clinic who we are offering TK and immunotherapy. There might be few patients who cannot get immunotherapy. So there is a trial called CABSON trial, which led to approval of cabozantinib single agent for intermediate and poor risk. They also compared it to sunitinib, which is a earlier first generation of TKI compared to second generation, which is cabozantinib. Progression-free survival and overall survival was the key endpoint. Results were in favor of cabozantinib for progression-free survival with hazard ratio of 0.66. Response rate was about 30% for cabo compared to 12%. Median overall survival, although numerically better for cabozantinib, did not meet its statistical significance. And again, both of them are tyrosine kinase inhibitors. So grade 3, grade 4 adverse events were very similar, about 67% in both arms. So this is also an FDA approved and in NCCN guidelines as a single agent for your patient who cannot get immunotherapy. Just a quick word, when we had this doublets, obviously now we are trying to improve on the doublets to get better response, better survival. So what the investigator did combine all the immunotherapy option, which was ipi-nivo, and combine it with the cabozantinib, which is a TKI. So essentially going from a doublet therapy to triplet therapy to see if we combine all the available active agent, do we get better response? So this is just recently published in NEGM, Cosmic 313. Very similar design to other trials, but they randomized it to ipi-nivo plus placebo versus cabozantinib and ipi-nivo. So basically comparing an immunotherapy doublet to immunotherapy TKI triplet. The study did meet its primary endpoint, which was progression-free survival with hazard ratio of 0.73. Something disappointing in this study was response rate. Even though we are combining TKI and immunotherapy, the doublet actually showed upwards of 60% response rate. But in this study, actually, we are seeing that the response rate for ipi-nivo, which is 40% known from other studies as well, but adding cabo didn't significantly increase that response rate. So this was disappointing. And overall survival is not mature yet, but we know doing triplet therapy definitely increases your side effect profiles. So as of now, doublet still remains the standard of care. It would be interesting to see if this triplet has overall survival benefit. And even if it's not accepted for all patients, I think what would be interesting to see if there's a subset of population we can tease out, which are at very high risk, very aggressive tumor, where this triplet therapy would be the ideal choice. But as of now, doublet still remains, and I don't think anyone has adopted triplet as of now in standard practice. So what's the next slide I want to talk about? What's the role of surgery, removing the primary, the source tumor in metastatic disease? We talked about oligometastatic disease, where you remove the tumor, you remove the metastatic site. But what is the role on patients who are on systemic therapy of just removing the primary tumor? So there was some retrospective data, which was before TKI era and immunotherapy era, which showed some benefit of removing the tumor, primary tumor, which led to the practice even in TKI era. And this is the study which was done in TKI era called Carmina study, where they were trying to prove non-inferiority of sunitinib alone compared to doing nephrectomy and sunitinib. And they could not prove, it met the non-inferiority cutoff for 1.2, the upper limit of confidence interval for 1.1, that proved that sunitinib by itself is not inferior to doing surgery. So basically, surgery is not indicated in TKI era based on this trial. We still sometimes do it for patients, our stage 4 patient, but mostly we are doing it for palliative reason, mostly pain control. So this study again was done in TKI era. We are now in our immunotherapy era, and there is a cooperative group trial looking at if there's any benefit of doing a nephrectomy in stage 4 cancer patient, renal cell type patients. But that study is still under recruitment. The data is not available yet. So we don't know in immunotherapy era if removing the primary tumor is beneficial or not. So this is a quick summary slide for how many options we have compared to not too long ago, when the only option was high dose IL-2 and interferon, which obviously was very toxic. So you can see there's multiple options, and most of these options honestly came out in the last 5 years or so. And again, we still use that IMDC criteria to figure out what is the best option for our patient. So just a quick word on when I see patients, renal cell patient in my clinic, what factors I discuss with them, what factors are in my mind when I'm recommending treatment option to them. The first thing is obviously histology. Clear cell having sarcoidoid features. Studies post hoc analysis have shown that immunotherapy, if you have sarcoidoid feature, which is an aggressive pathology, immunotherapy tends to have longer and durable and more response. So if you do have sarcoidoid, I do tend to favor immunotherapy combination. And the next we have kind of discussed throughout our presentation here, risk category. We know the favorable risk category is more VEGF dependent, so TKI is a better option. So we use TKI and immunotherapy in them. And if you have intermediate and poor, you can still use TKI and immunotherapy, but immunotherapy by itself, which is less toxic, is also an option. The other important piece of information is how symptomatic the patient is. As I've showed you multiple times, the response rate for TKI and immunotherapy is much higher than immunotherapy, and you get to that response faster. So I have a patient who has very symptomatic, or I recently had a patient with superior vena cava syndrome. I put them on TKI and immunotherapy because I need a good response and I need that response fast. The next thing which plays into role of deciding the treatment option is disease distribution. Is it more bone-only disease, which responds better to TKI, or if patient has brain mets, you want to avoid TKI in those patients because we know that RCC bleeds very easily, especially if that brain met is untreated. You do not want to expose them to VEGF inhibitor, which can increase their risk of hemorrhage. Another, obviously, performance status, medical comorbidities, what side effect profile is patient willing to accept goes into play when we are having discussion in clinic, what's the best treatment approach. And just one quick slide on second line option. Obviously, stuff you have not used in front line can be used in second line. So there's data of using immunotherapy if they're not exposed to immunotherapy front line. And compared to just doing everolimus, which has fallen out of favor, is an mTOR inhibitor, there's significant benefit of doing nivo as second line. Since most of the patients are exposed to TKI and immunotherapy upfront, my personal preference is honestly cabozantinib, which is a newer generation of TKI. So even if you have exposed to previous generation of TKI, it has proven to be still effective. So even if you have been exposed to, Lenvima or axitinib, you can still consider cabozantinib. And again, if you have not exposed to Lenvima, which is a newer generation, if patient got axitinib on cabo, you can expose them to Lenvima. And this is a third generation of TKI. These are all same class of medication. TKI, tivozanib, which actually after 2 lines exposure, and it can be 2 lines of VEGF inhibition, you can still get them a newer generation of tivozanib, newer generation of TKI, which is tivozanib. Just a few slides on future direction. We discussed about 2 major classes of medications, TKI and immunotherapy, and there's a lot of option in those combination. Where is the field for RCC heading next? As I showed before, hypoxia-induced factor is the main driving force for tumor genesis and kidney cancer. This is a simple slide just trying to show how hypoxia-induced factor works. If you have normal oxygen level, the pyruvate hydrogenase gene cluster hydroxylates your hypoxia-induced factor protein. Once it is hydroxylated, your VHL protein can degrade it. So if you have normal oxygen level, your VHL protein will degrade your hypoxia-induced factor. Now, if you're in a state of hypoxia, the pyruvate hydrogenase gene cluster will not hydroxylate the hypoxia-induced factor. And if it's not hydroxylated, VHL protein will not degrade it, and it will dimerize with this 1 beta form. And this dimer will lead to increased transcriptions. And this is the same mechanism the RCC uses for tumor genesis. So basically, VHL genes, either it can be a germline mutation or actually a sporadic mutation, but VHL protein function in RCC is significantly decreased. So even if you have normal oxygen levels and your hypoxia-induced factor has been hydroxylated, there is no VHL protein to degrade it. So basically, it forms the D-dimer regardless of oxygen levels, and downstream increases transcription factor, and that's responsible for your tumor genesis and angiogenesis. So once we knew this was a main driving force, the drug was developed. Merck developed a drug called belzutifan, which as of now has FDA approval only for germline VHL mutation, which in those patients, it has shown benefit response about 50%, but there are multiple trials ongoing because we know regardless of that germline mutation, hypoxia-induced factor is a major driver for RCC. So there are multiple trials ongoing with as a single agent for all comers, combining it with immunotherapy and combining with TKI. And we also have a trial at our institution looking at another hypoxia-induced factor, which we are very excited about. So this is one of the things which is in pipeline, and hopefully we'll get approval for all kidney cancer very soon. The next thing I have, as I've told you before, the main thing for metastatic disease, when we see these patients in the clinic, we're trying to risk stratify to figure out what's the best treatment option for them. And we have been using the risk stratification criteria, which was developed before the TKI era, before the immunotherapy era. So Dr. Renal at Vanderbilt, in collaboration with UT Southwestern, is trying to improve upon that risk stratification. The first goal is actually to risk stratify using a gene clusters. So basically to your clinical variables, Dr. Renal and his team is actually adding a gene sequence, a gene cluster to figure out how we can better risk stratify them. So this hopefully this will help with better prognostication. But a part of this trial is also to kind of predict who will respond better to TKI and who will respond better to immunotherapy. So based on his gene cluster data, he's going to assign patients to, patients who have genes which suggest response, which predict response to immunotherapy better will be randomized to ipi-nivo, and patients who have gene cluster which suggest more response to TKI will be randomized to nivo and cabozantinib, which is a TKI. So basically trying to improve on prognostic scores and actually trying to predict who is better suited for immunotherapy and who's better suited for TKI. So this is, again, we are, as oncology field, we are moving toward more individualized care, and this is what it looks like, involving genomics to figure out, to kind of predict who will respond better to certain treatments. Just a very few quick slides on non-clear, because this is such a rare and heterogeneous group of renal cell. There's not a lot of data until recently. There's 2 phase 2 studies which was presented at ASCO this year, which gives us some idea what systemic therapy option we have for these patients. But again, this is a very mixed bag of different histology of kidney cancer. So one of the study was a phase 2, was looked into nivo and cabozantinib. Again, you could give it front line and second line. This was just single arm study with objective response rate as the primary endpoint. And just the first row will shows us, you expect about 50% response rate in first line, about 40% respond in second line. So overall on EDBED, you expect about 50% response rate for the variant histology, non-clear cell. And very similar design for another Lenvima and Keytruda, again, a TKI and immunotherapy combination for non-clear cell kidney cancers. This trial only allowed frontline treatment. Again, single arm objective response rate was the primary endpoint. And this just bar graph showing what kind of risk, there are different histology, and then what kind of response rate to expect with this regimen. And this is a known fact that chromophobe is not immunogenic, doesn't tend to respond to immunotherapy. But as you see other histology, you expect about 50% benefit. And the 27% benefit you're seeing in chromophobe is most likely coming from the TKI alone. We don't expect to see benefit from adding immunotherapy. So those were my just quick slides on non-clear cell. And I will end, hopefully on time, with this last slide, just to showing how far we have come along. As I told you not too long ago, we didn't have much treatment options for kidney cancer patients. Those treatment options honestly was interferon and IL-2, and that was back in early 2000. And as you can see, the overall survival was 19 months. The second big change came when the TKIs came along, which significantly improved. And the modern era, which we are in right now, is the immunotherapy era. And as you can see, the overall survival, we have almost tripled the overall survival. And these patients are stage 4 cancer patients. So I'm hoping whatever survival data idea you had in mind when I asked the initial question, this surprises you that a stage 4 cancer, renal cell cancer patient, we are looking at median survival for almost 5 years. And with new drugs, completely new class of medications in pipeline, this will continue to improve. And in my mind, this is very close to actually curing a stage 4 kidney cancer patient. Thank you.
All right, thank you, Dr. Hijazi. I'm sorry, Dr. Kumar. There's a question in the chat from Dr. Hijazi. So
Okay.
let me see. Is Dr. Williams still here?
I am. I am
All right.
indeed. So just wanted to say thank you. That was a really comprehensive review. And obviously, as we were discussing before you started, that's a big change in what we used to expect from renal cell carcinoma. And before you get to Dr. Hijazi's question, just one quick question. When you listed the risk factors, one of them that was very much an issue in the south side of Chicago, and I imagine the West End here, was the sickle cell trait and sickle cell relationship. I didn't see that. Has that been debunked or no data for it?
It's still there, but it's a very rare, it's not all kidney cancer. Sickle cell is actually associated with medullary, which is a very rare type of tumor.
I see.
So it's still there that the sickle cell trait has still been associated with medullary cell tumor. But
Thank you.
It's not a risk factor for your the most common renal cell.
Dr. Hijazi, you had a question?
Yes, thank you, Rohit, for this presentation. And I haven't done renal cell carcinoma for over 7 years, but I remember that IL-2, which is like a T cell stimulator, used to be a treatment for a small group of those metastatic renal cell and has some cure. I know you don't do it no more. At least I haven't seen any of those patients come through, but it gives me this. Is the immunogenicity of this disease any different that we don't consider TILs therapy for those late relapse refractory, just like we used IL-2 for melanoma and now we are using TILs for it? Is that ever been explored as an option, or the idea is it's not going to work?
So the data obviously is not there. There's no trial, and maybe Dr. Chesley can open an RCC arm, but this is very immunogenic, right? We know that RCC doesn't respond to cytotoxic therapy, and even the IL-2 and the interferon we were giving before all this new drug came along, it was basically immunotherapy modulation. So I have no reason to not believe that TILs will not work. It's still the same therapy. So it would be interesting to see if they open an arm for RCC. But we know most of the RCC is immunogenic driven, and that's why we are seeing benefit of so many immunotherapies. So I want to believe that TILs might work. It's just that the data is not there yet.
And I'll chime in that we are thinking heavily about doing renal cell carcinoma with TILs. But we're trying to pick out the most effective genetic alteration, and I think it's going to be inducible IL-15 in TILs before we move on to less hot tumors than melanoma and lung.
Thank you, Dr.
Okay, any closing comments, Dr. Riley?
I know, Rohit, that was great. Thank you so much. And it's nice to see moving the needle like we are with a lot of immunotherapy. So I think that's always good news for patients and translating into long-term survivors. So thank you for that. And thanks for your work for moving the needle too.
Thank you.
All right. Well, that concludes things for today. Thank you, Dr. Kumar. It's wonderful and very informative, very pertinent. And we really just thank you for a great presentation. And Dr. Riley, thank you for facilitating. And this is great today. So thank you. Thank everybody.
Thank you.
All right. All right.